You've done everything right, paid your premiums, stayed on top of your health. But then you walk into the pharmacy and the total at the counter knocks the wind out of you. $400 for a medication you thought was covered. Why? The answer might be something you've never even heard of: the Pharmacy Benefit Manager, or PBM. Today, we're peeling back the curtain on these hidden players in the Medicare world. We'll look at how PBMs shape the price you pay for prescriptions and how new 2025 rules are finally putting them in the spotlight. This episode is about understanding your power as a patient, your rights under Medicare, and the business structures that influence your everyday care. Before we get into today's topic, I want to introduce myself. Hi, I'm Matt, your AI narrator. But don't worry, I'm not some robot in a lab. I'm a storyteller with some life experience baked in. I'm celebrating my 57th wedding anniversary this year. Still traveling, reading, cooking, and yes, still working. I've lived in Brooklyn, New Jersey, Colorado, and now Arizona. I studied chemistry at Stuyvesant High School, City College of New York, and earned my PhD at the University at Albany. For over half a century, OMG really, I've worked as a professional consultant with clients in government, NGOs, and commerce. My specialties: security, healthcare, and other areas that affect our daily lives. So if you're wondering, can this guy help me make sense of PBMs and Medicare? The answer is, I'll do my best. And if you ever want to drop me a note, joel@seniorpower.com. This is your Senior Power community. Before we get into today's topic, I want to introduce myself. Hi, I'm Matt, your AI narrator. But don't worry, I'm not some robot in a lab. I'm a storyteller with some life experience baked in. I'm celebrating my 57th wedding anniversary this year. Still traveling, reading, cooking, and yes, still working. I've lived in Brooklyn, New Jersey, Colorado, and now Arizona. I studied chemistry at Stuyvesant High School, City College of New York, and earned my PhD at the University at Albany. For over half a century, OMG really, I've worked as a professional consultant with clients in government, NGOs, and commerce. My specialties: security, healthcare, and other areas that affect our daily lives. So if you're wondering, can this guy help me make sense of PBMs and Medicare? The answer is, I'll do my best. And if you ever want to drop me a note, joel@seniorpower.com. This is your Senior Power community. Before we even get into PBMs or Medicare, let me tell you why we started this podcast and this whole channel in the first place. Our purpose is simple but powerful: to provide actionable information that helps you make informed decisions on your health, your independence, your safety, and your relationships. And not just in theory, but in ways that matter right now in your everyday life. Because the truth is, as we age, life gets more complicated, not less. The forms, the insurance letters, the new medications, the changing technologies, the shifting roles in our families, they all come at once, and often with very little guidance. This channel is here to say, you don't have to figure it out alone. It's about bringing everything together: health, mobility, security, family, friendships, and turning that knowledge into real improvements to your quality of life. Whether it's understanding a confusing Medicare statement or figuring out how to stay connected with friends across the country, we're here for it. We're doing this because seniors and their support networks face complex and overlapping needs, and they deserve tools that respect that complexity. The topics we cover are critical and timely. We don't wait for someone else to bring them up. We are proudly independent. No outside sponsors telling us what to say, and no hidden agendas. And our goal is to bring everything you need into one trusted place, not scattered across websites or buried in fine print, but clear, practical, and respectful. Because when you combine knowledge plus understanding, what you really get is senior power. The power to make your own choices, protect your well-being, and live life on your terms. And that's why we're here. Let's start with the basics. A pharmacy benefit manager is a private company hired by insurance plans, including Medicare Part D, to manage your prescription drug coverage. They're supposed to help lower costs. That's the pitch. But in reality, they often work like gatekeepers. They decide which drugs are covered, what tier those drugs fall into, what pharmacies are in your network, and how much your plan reimburses the pharmacy. Strange thing is, PBMs don't manufacture drugs. They don't treat patients, but they control access to medications and the prices you pay, and yes, they profit. A lot. Let's start with the basics. A pharmacy benefit manager is a private company hired by insurance plans, including Medicare Part D, to manage your prescription drug coverage. They're supposed to help lower costs. That's the pitch. But in reality, they often work like gatekeepers. They decide which drugs are covered, what tier those drugs fall into, what pharmacies are in your network, and how much your plan reimburses the pharmacy. Strange thing is, PBMs don't manufacture drugs. They don't treat patients, but they control access to medications and the prices you pay, and yes, they profit. A lot. They are a true oligarchy. Let's talk about who these pharmacy benefit managers really are. Three major corporations control most of the PBM market. CVS Caremark, which is part of CVS Health and owns Aetna Express Scripts, owned by Cigna Optum Rx, which is part of United Health Group together. These three giants manage over 80% of all U.S. prescription drug claims. That's right, 80%. But here's where it gets even more complicated. These PBMs aren't just managing benefits. They're vertically integrated, meaning the same corporation might also be your insurer and your pharmacy. CVS, for example, not only manages your pharmacy benefits, it might also be the one selling you insurance and filling your prescriptions. This kind of setup can lead to conflicts of interest. When one company controls the entire chain, from pricing negotiations to coverage decisions to pharmacy networks, they can set the rules to benefit themselves. So, when a drug is denied or a price seems higher than expected, it may not be your doctor or even your insurance plan making the call. It could be the PBM working quietly in the background, choosing what's best for their bottom line. And because these entities aren't always required to disclose how they negotiate rebates or decide drug tiers, their actions are often invisible to patients and even providers. That's why so much of the 2025 reform effort is aimed directly at them. The goal is to shine a light on practices that have long been hidden from view, because what you don't know can cost you. What have PBMs been doing? What have PBMs been doing? Let's take a closer look at how PBMs operated before the 2025 changes and how their practices shaped what you paid at the pharmacy counter. For years, PBMs have used a combination of tactics to maximize profits, often at the expense of transparency and affordability for patients. Here are 4 of the most concerning practices. Spread pricing. This is one of the most controversial PBM tactics. The PBM charges a health plan a higher price for a medication while reimbursing the pharmacy a much lower amount. The PBM then keeps the difference, or the spread, without telling either party. This practice can distort the true cost of medications and obscure who's profiting. Rebate walls. Drug manufacturers offer PBMs large rebates in exchange for favorable placement on a plan's formulary, but these rebates don't usually reach the patient. Instead, the PBM pockets them or shares them with the insurer, while patients may still face high out-of-pocket costs. This can lead to a perverse situation where more expensive drugs are covered while cheaper, equally effective generics are not. Tier manipulation. Medications are often grouped into cost tiers that determine what you pay out of pocket. PBMs have the power to assign drugs to these tiers. A drug placed on Tier 1 is inexpensive, but a Tier 3 or Tier 4 medication could cost hundreds of dollars a month. PBMs sometimes place drugs in higher tiers, not for clinical reasons, but because it benefits their business deals. Pharmacy steering. PBMs may require you to use a specific pharmacy, often one they own or have financial ties to. For example, they might steer you away from your neighborhood pharmacist and into a mail order program run by their corporate partner. This not only limits your choices, but can reduce care coordination and delay access to needed medications. These practices were largely hidden from view, buried in contracts, and shielded by a lack of public disclosure. And for years, seniors bore the burden, paying more, navigating confusing formularies, and often not knowing why a drug was denied or why a price jumped. But with pressure mounting from lawmakers, watchdog groups, and patient advocates, 2025 marks the beginning of long overdue transparency. We'll talk about those changes in the next segment. 2025 is the year some long overdue reforms are finally hitting the books. The Inflation Reduction Act of 2022, combined with new CMS regulations, has brought some of the most significant changes to Medicare Part D since its inception. Let's talk about what's different this year, because reforms are designed to cut through the secrecy, reduce out-of-pocket costs for beneficiaries, and hold PBMs more accountable for how they operate. Here are just some of the major changes now in effect. Annual out-of-pocket cap. For the first time in Medicare history, there is a hard cap on out-of-pocket spending for prescription drugs under Part D. In 2025, the cap is set at $2,000 per year. Previously, once you entered the catastrophic phase, there was no limit to how much you could continue paying, especially if you needed high-cost medications. Now, once you reach $2,000 in spending, you won't pay any more for the rest of the year. This is expected to significantly ease the financial burden for seniors with chronic conditions or expensive treatments. Elimination of the coverage gap, donut hole, the complex coverage gap phase, once known as the donut hole, is now essentially eliminated. The new benefit design simplifies the structure into an initial coverage phase, followed directly by a protection phase after the cap is reached. Seniors will no longer face the confusion or cost spikes associated with bouncing between stages. PBM transparency and reporting requirements. PBMs must now submit detailed reports to CMS disclosing all rebates, discounts, service fees, and post-sale compensation they receive from drug manufacturers and pharmacies. This includes reporting how much of those rebates are passed on to insurers and whether any are shared with beneficiaries at the point of sale. CMS will use this information to detect anti-competitive practices, excessive markups, and formulary manipulation. These transparency requirements are expected to curb PBMs from pocketing undisclosed profits, while patients continue to pay high costs at the counter. Medicare drug price negotiation. Medicare now has the power to directly negotiate prices for certain high-cost drugs under Part D. In 2025, the first 10 drugs selected for negotiation will have maximum fair prices established. These drugs were chosen based on Medicare's spending and lack of generic competition. Future years will expand the list significantly. The negotiated prices are expected to reduce costs for Medicare and beneficiaries alike, especially those using blockbuster drugs. Redesign of the Part D benefit structure. Plan sponsors and drug manufacturers are now required to cover a greater share of drug costs after a beneficiary hits the out-of-pocket threshold. PBMs can no longer shift most responsibility to Medicare in the catastrophic phase. This creates incentives for PBMs to manage costs more effectively upfront, rather than relying on government backstops. Ban on spread pricing in Medicaid. Spillover to Medicare likely. While the current ban on spread pricing targets Medicaid, the regulatory trend and pressure from Congress suggests similar scrutiny is coming to Medicare Part D. CMS and FTC are actively investigating spread pricing abuses in Medicare, including hidden markups on pharmacy reimbursements, generic and biosimilar tiering reforms. CMS is mandating that generics and biosimilars be considered for lower cost tiers unless a clear clinical rationale exists. PBMs must justify placing lower cost options on higher tiers, a move aimed at preventing rebate traps that benefit PBMs but harm patients. The goal is to improve access and affordability while promoting market competition. These reforms are still rolling out, and many beneficiaries may not see all the benefits immediately, but they represent a significant shift toward transparency, fairness, and patient-centered care. And while PBMs are adapting, sometimes finding new ways to shift costs, these changes mark a turning point. For the first time in years, the rules are starting to favor the people who need the medication, not just the middlemen profiting from it. So now that we've uncovered who PBMs are, what they've been doing, and how the 2025 reforms are changing the game, you might be wondering, what can I do about it? The answer is quite a bit. While many of these reforms are systemic, the choices you make and the actions you take still play a huge role in protecting your wallet, your health, and your peace of mind. Here's a breakdown of what you can do as a Medicare beneficiary, caregiver, or advocate. Review your plan carefully during open enrollment. Every fall, you get the opportunity to compare Part D drug plans and switch if necessary. Use Medicare's official Plan Finder tool to look up your medications and compare prices, pharmacy access, and out-of-pocket limits. Pay special attention to formulary changes. Some plans may drop or re-tier your medications from one year to the next. Ask your pharmacist questions. Don't assume the price you're quoted is the lowest available. Ask, is there a lower cost alternative? Or would a different pharmacy be cheaper under my plan? Pharmacists are often aware of PBM restrictions and can help you navigate around them. Appeal and challenge denials. If your plan refuses to cover a drug, you have the right to file an appeal. Talk to your doctor to write a medical necessity letter and file a redetermination request with your insurer. Appeals often succeed when patients show documentation and persistence. Report unfair practices. Call 1-800-MEDICARE or contact your state health insurance assistance program, SHIP, if you believe a plan unfairly denied coverage, prices are inconsistent, or a PBM has steered you to a restricted pharmacy. These reports help regulators spot patterns and push for further reform. Keep records and stay informed. Maintain a folder with your prescriptions, receipts, coverage decisions, and denial letters. Record drug prices at different pharmacies and track when and why they change. Sign up for Medicare newsletters, senior advocacy alerts, or community education events to stay current. Support policies that promote transparency. Call or write your elected officials in support of federal and state efforts to regulate PBMs and require full disclosure of rebate and pricing arrangements. Many advocacy organizations, like AARP and the National Council on Aging, offer easy tools to participate in letter-writing campaigns. Educate and empower others. Share what you learn with friends, caregivers, and family members. The more we understand how the system works, the better we can help one another make smarter decisions. Remember, this isn't just about saving money, though that matters. It's about getting the care you need without unnecessary stress or confusion. Every question you ask, every call you make, every appeal you file, it pushes the system toward fairness. Because when enough people speak up, the rules change. You've just taken in a lot, and that's no small thing. PBMs, Medicare, Part D, formularies, appeals, price negotiations, reforms. It's a complicated system by design, but here's what matters most. You are not powerless. You're not too late. You're not too old. And you're not alone. What's changing in 2025 is important. Caps on out-of-pocket costs, more transparency, more oversight, more power in your hands, if you know how to use it. And now, you do. You know that there are steps you can take to ask the right questions, to challenge unfair denials, to share what you've learned with someone else who might be struggling. That's what this podcast, this community, is all about. Not just information, but connection, action, and support. We believe that when you combine knowledge with understanding, you don't just get smarter, you get stronger. That's what we call senior power. So don't keep this episode to yourself. Send it to a friend. Talk about it at your next appointment. Bring it up in a group. Be the person who says, yes, we can do something about it, because you can. And we'll be right here every step of the way. Before we go, just a quick reminder. If you found today's episode helpful, go ahead and click that subscribe button so you don't miss the next one. Give us a like if this helped you feel a little more confident or clear. And most of all, share this with someone you care about, a neighbor, a friend, or a family member who's facing these same questions. Together, we're building a community that supports each other, one smart step at a time. Because that's what senior power is all about.